Okay, good evening, everyone. I'm Dr. Guru Prasad Hosurkar. I'm a senior consultant neurologist at Columbia Hospital, Yeshwanthpur, Bangalore, unit of Manipal Hospitals now. I'm also a patron of BNET. We've been doing this webinar since the last year, since the COVID times, and we're continuing this series of webinars this year as well. I welcome all the speakers, our esteemed chairman, Dr. Sharma, for this meeting. Last time we had a webinar on neurology, vertigo, basically approach to vertigo. This time we have an interesting topic. We all deal with neuro-ophthalmology issues in our practice, very common issues, and common plus also sometimes complex. We need to collaborate with our ophthalmology colleagues for both diagnostics and therapeutics for various ophthalmological conditions, neuro-ophthalmological conditions. So we have three topics to be discussed today. One is a clinical approach. Dr. Viswanathan will be deliberating on that. Dr. Abdul Rauf, who's a senior ophthalmologist from neuro-ophthalmologist from Narayana Nethralaya, will be talking on approach to disc edema. And then Dr. Sujit, my good friend from Apollo Hospital, Chhatrapati, will be talking on approach to optic neuritis. I would now welcome Dr. G.R.K. Sharma. Can I have the slide, introduction slide? So Professor J.R.K. Sharma is the head of the department, professor and head department of neurology at St. John's National Academy of Health Sciences. It's been quite active. He's also running series of webinars on therapeutics. Quite happy to have him as a chairperson to this. And I'm told neuro-ophthalmologists were quite dear to me, quite dear to him. I would now hand over to Dr. Sharma. Sharma, sir.
Thank you, Dr. Guru, and the BNET team for inviting me for this program. It's a very important program, and I must thank you for taking up neuro-ophthalmology. It is rightly said that the eye is a window to the brain. It is not an exaggeration. If you look at the fact that 60% of the brain is connected to the eye in some way or the other, connected to the visual system, which means that every alternate neurological conditions which we see will have some neuro-ophthalmological manifestation. If you are not picking up, that means we are not examining thoroughly. That is what it means. Earlier, this was mainly of academic interest, neuro-ophthalmological findings, but now it has gained more clinical relevance. Very important neurotherapeutic advances have taken place. We'll be discussing that in the next few minutes. We'll start without any further ado. The first talk by Dr. Viswanathan. He'll be talking on unraveling the eye movement, extraocular movements and disorders. Dr. Viswanathan.
Thank you very much, sir, for the introduction. I thank the organizers at BNET for giving me this opportunity to speak on this very important topic, which is basically the physiology of extraocular movements. Just a confirmation, can you see my screen?
Yes. Yes, Viswanathan. Go ahead.
Yes. Okay. So, disclosures wise, I have consent for the patient only for educative purposes. And I've used various internet resources and books, pictures in this talk. The purpose of extraocular eye movements is to scan the environment and keep the object of interest on the fovea. Eye movement physiology has many components, and a good understanding of this is somewhat crucial to localization and also to sometimes even in the diagnosis. So I will basically give my talk on one, the eye movements and the muscles that govern them, and briefly on how to assess third, fourth, and sixth nerve palsy. An overview on the neural control systems that govern various types of eye movements and a few commonly seen abnormalities. So as we all know, there are 6 extraocular movements, 6 extraocular muscles, 4 recti and 2 obliques. Now, the way they are attached to the eyeball basically governs the kind of movement they produce. When you look at the rectus, especially the medial and lateral, they have only one single movement, that is movement on the horizontal plane. Whereas the superior rectus, the inferior rectus, and the obliques have other movements as well. This is mainly because, as you can see in the figure below, the axis that passes through the orbit and the visual axis are not aligned. And the way the muscles attach, especially the superior and inferior rectus, is along the axis of the orbit. So this automatically brings in some degree of obliquity in its attachment, causing the eyeball to rotate when the muscle contracts, which is one. And also, it also pulls up or pulls down the eyeball, which is two. And in certain axes or in certain directions of gaze, they may act purely as vertical and upward or downward acting movements, or they may also pull the eyeball to either side. So the obliques will basically abduct. You can remember OB and AB. And obviously, in addition to torsion. And when the oblique muscles, when the eye is adducted, acts as a pure elevator and depressor. With this knowledge, there are some laws. Specifically, when it comes to clinical practice, that there is one very important law, which is Hering's law. Basically, for one particular eye movement, the corresponding muscles, that is the yoke muscles, say for example, when you look to the right lateral rectus, the left medial rectus, they will receive equal amount of inhibition. And the Sherrington's law says that when the agonist is contracting, the antagonist must relax. So these two laws are very important, at least when it comes to bedside interpretation of eye movement abnormalities. So as I said previously, there are various yoke muscles, like say when here when the patient is looking up and towards the right side, the right superior rectus and left inferior oblique act in unison, and they are the yoke muscles. And similar yoke muscle pairs have been mentioned in other directions of gaze. You can also see a pattern here that when we have vertical movements, you have a combination of a rectus and an oblique. When we start examining the patient with respect to eye movement, we look at the primary position, how the eyes are aligned. When they look straight and the visual axes are parallel to each other, we call it orthotropia. When one eye is pointing inwards, we call it esotropia. When it points outwards, it's exotropia. When they point away from each other, we call it a disconjugate kind of alignment. And when the eye moves to the same side, we call it a conjugate movement. Sometimes these disconjugate movements can happen in the vertical plane, and particularly when they are because of supranuclear abnormalities, we call them skew deviations. We assess extraocular movements in the 9 cardinal positions, out of which the positions which are to the right and left are more useful as they help isolate individual muscles better than just looking straight up or straight down. These movements are governed by 3 cranial nerves, all of which are situated either in the midbrain or in the pons. The third cranial nerve, or the oculomotor nerve, is at the level of the superior colliculus. The fourth cranial nerve, or the cochlear nerve, is at the inferior colliculus, and the sixth cranial nerve is in the pons. Now let's have a few illustrative examples. Here, this patient in primary position. You see that the left eye, 1, there is ptosis. 2, if you look carefully, this eye is pointed outwards and downwards. And in the other positions of gaze, the patient is asked to look to the right side. You see that the left eye is not. And similarly, all movements both up and down, this eye does not start. And this eye does not go up when you ask the patient to look up to the left and upwards. However, when he's asked to look left and downwards, there is some movement, mainly because oblique may have some kind of depressive effect. and the oblique, as we know, is supplied by the fovea. So, in addition to these abnormalities, the pupillary involvement may or may not be there. As a dictum, we mean that when compressive lesions are present, like an aneurysm or herniation, you develop pupillary involvement. However, this may not always be the case. Partial third nerve palsy sometimes can be quite tricky. Now, how can we localize based on these findings? The third nerve can be affected right from the level of the nuclear region all the way up to the nerve, and sometimes neuromuscular junction and muscle disorders may also mimic the third nerve, though technically they are not third nerve palsies. So here, when we have a nuclear lesion, when we examine the nucleus of the third nerve, we notice that there is only one single nucleus called as a central caudal nucleus, which is for the levator palpebral superioris. And the superior rectus subnucleus basically sends out its fiber, which crosses over into the other side and comes out. So suppose there is a lesion, say here, we have the single nucleus that governs the levator palpebral superioris has got damaged. One side of the superior rectus nucleus has got damaged. However, you see the fascicles from the other side are also passing through. So you get a double superior rectus palsy. You get bilateral superior rectus palsy. And of course, you get a third nerve palsy on the affected side. So this is how one can differentiate a nuclear lesion versus, say, a fascicular lesion. The fascicular lesions are differentiated by the other associated signs and symptoms that can be there. Say a person has tremor or ataxia or hemiparesis. So these basically are what are called cross syndromes, where they are affected on the other side of the third nerve palsy. Like in Weber, you have contralateral hemiparesis, etc. So that would again tell us it could be a fascicular lesion. Commoner lesions of the third nerve are usually in its subarachnoid course and through the cavernous sinus region. Next, coming to sixth nerve palsy, which is probably the easiest of the three to diagnose. Well, the patient mainly will complain of diplopia, which is where the images are separated horizontally and to be predominantly for distant optics. And when you look at the primary position here in this particular picture, it is not very evident, but sometimes patients may have a slight esotropia. And always in all cases of sixth nerve palsy, always look for features of raised ICP and papillary. And most of the time, unless it's very, very subtle, sixth nerve palsies are very hard to miss. So again, sixth nerve abnormalities may occur from the nucleus, vesicle, subarachnoid space, petrous apex, cavernous sinus, and in the orbit. When it occurs in the nuclear region, it may have other associated abnormalities like a 1.5 syndrome. It may have a facial nucleus abnormality resulting in a ipsilateral element type of facial palsy. It may involve long tracts. It can cause ataxia depending on other cerebellar connections involved in the pons. So depending on those abnormalities, we may be able to tell that it could be an intraaxial cause of a sixth nerve palsy. And of course, petrous apex lesions will form the characteristic Credinego's syndrome triad. So we'll have to look for those features also when we are dealing with a patient with sixth nerve palsy. And other associated cranial nerve abnormalities like fifth and third may be more common in cavernous sinus lesions. When there is vertical diplopia, now that is where it becomes a bit challenging for a non-neurologist. We depend on what is called as a three-step approach, especially for trochlear nerve palsy, which is one of the common causes of vertical diplopia. And we will go through this step, this particular clinical vignette with three questions. One, when the patient is looking straight, which eye is hypertrophic, that is higher than the other eye. When we look to the left or right, where is the diplopia most severe? And when you tilt the head to either side, when is the diplopia most severe? So we use this particular diagram where we just write the yoke muscles, like how when the patient looks up to the right and upwards, the right eye superior rectus and the left eye inferior oblique activator. So we just write out the corresponding yoke muscles and we go forth and examine the patient. So here, when the patient is looking straight, we see that this left eye is slightly upwards compared to the other side. Now, this could mean two possibilities. One, there is a possible weakness of the depressors of the left eye, or there can be a weakness of the elevators of the right eye. Now, if you recall the Herring's law, equal innervation. So when one side there is a paralysis, the brain tries to send more impulses, so it results in an overaction on the other side. So that may explain a left eye hypertropia. Now, so we first write that down. So we put a red rectangle over the possible muscles. So it could be a weakness of the depressors left eye, that is superior oblique inferior rectus, or the elevators of the right eye, which is superior rectus inferior. Next, we ask the patient to look to the side. So here, patient looks to the right, looks to the left, looks to his left. Now we see that when the patient looks to his right, patient's right, the hypertropia is more, which is demonstrated by the prism diopters here. So the more the prism diopters, the more the hypertropia. So here you see that it is much more. So which muscle is the one that causes depression in the adducted position, which would be the superior oblique? And that we will mark with a green rectangle. And the other muscle that can act as a depressor in the adducted position will be an elevator in the adducted position will be the inferior oblique. However, an inferior oblique palsy will not result in hypertropia, so that is out. And the next step that we do is we tilt the patient's head to either side. So here the patient's head is tilted to the left, and obviously it is more, and when he tilts to the right, it is not as much. So when we look straight and then we tilt our head to the left side, now the eye has to compensate by tilting inwards, in cyclotorsion. And we must always remember that the superior is intort. So that is what is marked here as an intorsion. So, of course, it is not a superior rectus palsy as the eye is hypertrophic. Therefore, all rectangles converge on one single muscle. Right? So, therefore, the muscle affected here is the superior oblique. And therefore, superior oblique is supplied by the trochlear nerve, so it's a trochlear palsy. When you look at the fundus closely, sometimes you may notice that it sometimes may be very difficult to appreciate at bedside, but the fovea may be slightly at a lower level compared to a horizontal line drawn from the center of the disc. So this may also indicate that the eye has had a torsional abnormality. And again, the trochlear nerve can be affected from all the way from the nucleus to the nerve fibers. It is difficult to differentiate between a nuclear and a fascicular trochlear palsy. An associated ipsilateral corner syndrome may point to an intraxial abnormality. Now we are done with the extraocular muscles, movements, and nerves. Now the brain controls all of these muscles and these nerves to move in certain directions to help us scan an environment and fix on objects of interest. To accomplish that, there are a number of systems that help us accomplish these tasks. One is the saccadic eye movement. You have the smooth pursuit. You have the vergence system. You have the vestibulo-ocular reflex system, the optokinetic movements, and the fixation system. So we will go through these quite quickly. Now, Saccades are rapid movement. So we are looking at the TV and suddenly something falls in the kitchen, we immediately look to in that direction. So that movement is a saccade. So these are fast. So they help shift our gaze quickly from one object of interest to another. So they have to be fast. And the latency may be up to 200 milliseconds. That is, from the time you get a stimulus to initiating that saccade, it takes about 200 milliseconds. And the saccade as such lasts for a very short time, lasts only for 20 to 30 milliseconds. So this is a so here we see that person is looking from side to side. These are fast eye movements. Saccades need not only occur when we are shifting from one object of interest to another. Sometimes they also occur when we are scanning an object. Say we're looking at this lady's picture, and when we track the eye movements, we see that there are these fast saccades that go all over the picture, so that the brain gets an entire view of the image clearly. Visually guided saccades are again stimulated uh, by objects that fall on the retina and excite our brain. They may be reflexive. This reflexive saccade can sometimes be even to auditory stimulus. They can be a scanning saccade, as what I showed earlier. Sometimes they can be anti-saccades, predictive saccades, etc., which are more used for research purposes. Anti-saccades are to an extent used at bedside, especially in the HIV-associated dementia. When you look at the scoring system, anti-saccades are one of the tasks that are given to the patient. Basically, it tests the dorsolateral prefrontal cortex, and it is a test for disexecution. So there are various parts of the brain that are involved in generating these saccades, right from the frontal eye field is probably the most important supplementary eye field. The dorsolateral prefrontal mainly for predictive saccades, memory guided saccades, and anti-saccades. And reflexive saccades are more to do with the parietal eye field as well as the superior colliculus. The circuit in some detail. So we have the fibers rising from, say, you want to look towards the left side, it starts from the right frontal eye field, goes down into the brainstem, crosses over, and goes to the PPRF. And the PPRF has various interneurons that connects the abducent nerve, and a subpopulation of the neurons in this nucleus form the medial longitudinal fasciculus, abbreviated as the MLF, towards the opposite side to the medial rectus. So when the PPRF gets stimulated, it stimulates the sixth nerve, which causes the eye to go to the same side, and it also stimulates the opposite side, third nerve, so that there is a conjugate movement of the eyes to one side. So this is in brief about this circuit, and this is important for something known as internuclear ophthalmoplegia, which we will see later. Vertical saccades are generated by another group of structures in the rostral midbrain, that is the higher parts of the midbrain, called as the rostral interstitial medial longitudinal fasciculus and the interstitial nucleus of Cajal. There are various other subnuclei that help us generate the vertical gaze and also sustain them. So a little bit about INO. So we saw earlier that there is a nerve fasciculus called as the medial longitudinal fasciculus in the brainstem, connecting the pons up to the midbrain, sixth nerve to third. Now say that the left medial longitudinal fasciculus gets damaged. There is a slight difference between the orientation of the brainstem and the picture, so pardon for the confusion. So when the patient is looking at the primary position, it looks okay. Patient looks to the right, it looks okay. The patient is looking to the left. What happens is that the left abducent nerve looks towards the left side is fine. But as the medial nostril fasciculus crosses over towards the right third nerve nucleus, the eye fails to adduct. So this results in one, a nystagmus of the abducting eye, and the eye fails to adduct on the side of the medial longitudinal fasciculus. So we always label the INO based on the side on which the eye fails to adduct. So if the right eye is not adducting, it's called a right medial longitudinal fasciculus. If the left eye is not adducting, it's a left medial longitudinal fasciculus involvement. So it's a left eye. Same thing can happen where you have a lesion in the PPRF. So, and as well as the medial longitudinal fasciculus. So here, all movements are lost except the eye moving to one side, that is on the other side, the eye will be able to abduct. But otherwise, the eyes just cannot move. This is called as a 1.5 syndrome. These are commonly seen in demyelinating disorders and itch stroke. Next, we have a smooth pursuit movements, which are slow tracking movements occurring around 4 degrees per second, and they help to track a moving stimulus. And this develops by the 6th month of life, when the child starts learning to follow objects of interest to them. So here we see the eyes following the finger. This is a slower movement than a second. So you have different types of circuits that are involved in smooth pursuit. The open loop pursuit is in the beginning when we start the pursuit, and here it lasts for about 100 milliseconds. That part of the pursuit may be a bit jerky and a little fast. Subsequently, the various neural circuits learn to calculate the velocity at which the eyeball is moving and the target moving on the retina, and it matches both and it becomes uniform. So what are the circuits that are involved? The pursuit circuits are slightly complex, but mainly it involves occipital cortex and the parietal eye field and various parts of the cerebellum. The oculomotor vermis abnormalities can result in a hypometric saccade and impaired pursuit. In vestigial nucleus involvement, you have an impaired circuit, but hypermetric saccade. So what does it mean is, suppose you have to look to, say, an object onto your right and then onto your left. When you look onto the left, your eyes overshoot the target in hypermetric and undershoot in hypometric. So the eyes goes and then comes back. So that will tell you that it could be a hypermetric saccade, and if it undershoots, it's a hypermetric saccade. In flocculus and paraflocculus nodule involvement, you will have an impaired vestibulocular reflex as well as an impaired pursuit. So various lesions of the cerebellum can also cause abnormal pursuits. Coming to vergence, which is basically a movement of eyes in opposite direction. When an object comes from far to near you or from near to far, we will go a little fast because we are running out of time. So here the finger goes in and out. You can see the eyes converging and diverging. And this is a pathway for the convergence, which basically starts from the occipital lobe, which sees the object coming near and far, and it goes to the convergence area in the rostral membrane, which then stimulates the third nerve as well as the sixth nerve through various interneurons. The vestibulo-ocular reflex is also called as oculocephalic reflex, and which can occur independent of visual stimulus. They may be rotational, translational, and counter-rolling responses. This is also similar to the circuit we saw earlier, but the stimulus comes not from the frontal lobe, but from the semicircular canals and from the vestibular apparatus. Next, coming to the optokinetic movements. Here, when an object is moving across a visual field, like say we are staring out of a window in a train and we are looking at the background moving, so that generates what is called as an optokinetic response. So here, if we try to look at this grating moving from one side to another, we have this slow pursuit that goes in the direction and then a corrective saccade that takes us back. This is called as an optokinetic nystagmus. and this is elicited by an optokinetic drum. This is an often neglected part of neurological examination, but it is quite useful, especially in children where we suspect poor vision and they're not cooperative. We can use an optokinetic tape. When there is functional vision loss, patient denies that he's not able to see anything. OKN can sometimes be a reflex phenomenon. You do a full field OKN, patient may have nystagmus, and that may raise the doubt of functional vision loss. It may help pick up subtle internuclear ophthalmoplegia. The adduction defect can be picked up much better. A vertical drum roll can be used to identify convergence retraction nystagmus in Parinode syndrome. In parietal lobe lesions, the corrective saccade is lost when the drum is spun towards the side of the lesion. So this is another localizing value for an OKN. And impaired in diseases with abnormal saccades like in PSP. The fixation system is probably the least studied of all of these systems, and they are just there. That we are fixing on objects as these subtle movements of the eye, which are of very, very low amplitude and high frequency. One way to test them is if you look closely onto the screen and fix onto that red dot, after a while you'll notice that this circle around this dot disappears. So why that happens is when we voluntarily try to focus hard, we can to some extent abolish this fixation system. The visual receptors gets adapted, and when the visual receptors get adapted, then you stop sending impulses from the retina to the brain, and therefore the objects disappear. So the fixation system is important. If they are not there, we probably will not be able to see anything because the retinal receptors will get rapidly adapted. And many of the optic illusions that you see on social media and WhatsApp forwards are all because of these subtle movements that the fixation systems create. So in conclusion, knowledge regarding eye movements is essential for everybody, all practicing neurologists, physicians. A lot of information can be gained with simple bedside tests. There's nothing complicated. If you practice, repeat, and you revise, it will lead to fluent understanding and quick application at the bedside. Thank you very much for giving me a chance to speak on this topic.
Thank you, Dr. Vishnu. It was an excellent presentation. A very complex topic you have simplified nicely and presented. Of course, in the short time, it is not possible to cover all the aspects. So let us see if any questions are there. We will take up in a few minutes. But now I don't see any questions. Shall we move on to the next topic, Dr. Guru? We can take up the questions at the end.
Yeah, we can take the questions at the end.
So, Dr. Vishnu, you please stay back and
sure, sir.
we'll take up the questions.
Thank you.
So, thank you. Now I invite the second speaker, our Neuro Ophthalmology consultant, Dr. Abdul Rabu from Narayan Netralaya, to speak on another important topic, approach to bilateral disc edema. Dr. Abdul, please take over.
Thank you, sir. I thank everybody for giving me the chance, and especially to be with such distinguished persons. I'm extremely happy to share a stage with you. I'll share my screen now. Good evening, everybody. I think I'm audible and the screen is visible, right?
Yes, sir. Please continue.
Coming to how do you approach a case of optic disc edema, since I've been given bilateral optic disc edema, just the basic that disc edema can be unilateral or bilateral, and in either case, it can be a true disc edema or a pseudo disc edema. So, since I'm talking about bilateral optic disc edema, we need to keep in mind some causes of bilateral optic disc edema. Most important would be accelerated or malignant hypertension, that we call grade 4 hypertensive retinopathy, papillary with raised ICP, bilateral papillitis, infiltrative optic neuropathy, compressive optic neuropathy, diabetic papillopathy, bilateral dysthyroid orbitopathy, bilateral idiopathic orbital inflammation, bilateral posterior uveitis. And in case of raised intracranial pressure, most common what condition we see is idiopathic intracranial hypertension, or maybe head trauma, or in space occupying lesions, cerebral venous thrombosis, renal hemorrhage, meningitis, obstruction to the ventricular system, and very rare is a choroid plexus tumor. And coming to pseudodisc edema, there are a few classical causes: drusen of the optic nerve head, juxtapapillary myelinated nerve fibers, a crowded optic disc where it appears a little small, that's it. High hypermetropia may show a pseudodisc edema, or a tilted disc may give the appearance of disc edema. So this is a finding which we come to actually, an optic disc edema after we have done an examination. So before you have come to a diagnosis of optic disc edema, we should have already done these things: an accurate visual acuity, color vision in both eyes, looking for sluggish reaction to pupil or a relative apparent pupillary defect, extraocular movements for double vision, or possibly you can identify the first or the sixth cranial nerve palsy. And painful eye movements would be in optic neuritis or posterior scleritis. Thorough retina evaluation, ask for floaters, vitreous cells, where in posterior uveitis you can have bilateral disc edema. VK syndrome very classically presents as bilateral sometimes. Proptosis if there is thyroid eye disease, idiopathic orbital inflammation. And if there is globe tenderness when you touch the eye, especially in posterior scleritis or in optic neuritis, the superior part I've seen is most often tender. Papilledema should be reserved for cases of bilateral optic disc edema due to raised intracranial pressure. And space occupying lesion should always be ruled out. And we should have already known about should ask for symptoms. Once you have come to a diagnosis of bilateral optic disc edema, you should ask whether headaches are there, what type of headache, when is the headache, and neck stiffness, transient visual blurring, pulsatile tinnitus, double vision, dizziness, nausea, vomiting. These are all symptoms of raised intracranial pressure. And specific visual symptoms such as transient visual obscuration, blurring of visual field loss, diplopia, decreased vision, or color vision abnormalities. What I would do first is when I see a case of papilledema, due to bilateral optic disc edema, immediately I'll go and check the blood pressure. The first thing one should do is check the blood pressure. This is the case of bilateral disc edema. So you see there are multiple white.
Sorry, Dr. Abdul. There's a problem with your audio. Can you check? Huh? Your voice is breaking. Your voice is breaking. There's a problem with your audio. Can you please check? You're not audible, not well audible. No.
Headphones, or that will probably help. Bluetooth device or headphones.
Sir, you have to disconnect your headphones, the Bluetooth from your laptop. We cannot hear you, sir. So next to the mute button, there is a small arrow. I'll just stop sharing. Next to the mute button, there's a small arrow. Just click on that and select your microphone, sir, the laptop microphone. Just change the microphones. Next to the mute button, there's a small arrow. Click on that, and in select a microphone, it would be connected to your Bluetooth. Just change it to your laptop microphones. No, sir, we cannot hear you. Maybe if you can leave and join again, sir. We cannot hear you, sir. So can we go to Dr. Sudhir's presentation now? We will just call Dr. Abdul to sort it out.
Sure, sure. Sujit, can we do that? Dr. Sharma?
I think we can, yeah, we can do that.
Yes, sir, I'm here. We can start off till we sort out the technical problems.
Yeah.
Sorry about this inconvenience. I invite Dr. Sujit, who is a consultant neurologist and epileptologist in Apollo Hospitals, Bangalore, to talk on the third topic, that is optic neuritis. Dr. Sujit, please take over.
Good evening, everybody. We are sorry about the technical problem which Dr. Abdul's presentation has. I'm sure it will be sorted out shortly. At the very outset, I'd like to thank BNET organizers, Dr. Guru Prasad, Dr. Umashankar, and all of them for having done this wonderful symposium on neuro-ophthalmology and, of course, giving us an opportunity to speak about various topics. I also would like to thank the chairperson, Dr. Sharma, who incidentally has been my teacher who initiated me into the world of neurology during my MD. So I'm rather happy to be presenting in front of Sharma sir as well. My topic for today is approach to optic neuritis. Sir, am I audible?
Yes,
Sujit.
Okay, sir. So, well, these are famous words of one of the greatest surgeons, Sir William Osler. To study the phenomenon of disease without books is to sail an uncharted sea, while to study books without patients is not to go to sea at all. So this is the principle with which we conduct CMEs and teach students. So learning from patients is the most important thing. So my talk will revolve around clinical vignettes and the theory around it. So before I start, I'd like to just think of two of my teachers. One is Professor Vivek Lal, who taught me a lot in neuro-ophthalmology, and Professor Dinesh Naik, who initiated me into epileptology, and both of them continue to be my mentors. We'll start with a case. This is an 18-year-old girl who presented with a history of decreased vision in the left eye since 2 days. Now, she had a preceding history of fever 2 weeks back with a slight sore throat which lasted for 1 day. Examination, as Dr. Abdul was telling us, the best corrected visual acuity in the left eye was 6/96. There was a relative afferent pupillary defect in the left eye. The color vision was impaired in the left eye, and the left eye on fundoscopy disc was mildly edematous. The visual field examination showed a centrocecal scotoma. So here you can see that this is the left eye. I don't know if my arrow is visible, but you can see there's a definite blurring of the disc margins, whereas it is very clear in the right eye. This is what we see in optic neuritis. And this is what the visual field showed. This is a Humphrey visual field, which is showing a centrocecal scotoma in the left eye. And the MRI showed this is a diffusion restriction imaging, which is showing diffusion restriction in the left optic nerve, which appears bright on flare imaging, and it appears a little edematous. If you compare it with the right eye, you can see that it is edematous and slightly swollen. And there appears to be a contrast enhancement of the left optic nerve as well. So what we are seeing here is an optic neuritis. And this is clearly could be made out in the history, which showed a pre-existing preceding viral illness followed by an autoimmune demyelination. So here the remaining tests showed that the CSF cells protein was slightly elevated, whereas the cells were negative, oligoclonal bands were negative, and all markers, autoimmune markers as well as NMO spectrum disorder markers were negative. So this was a case of left optic neuritis, probably post-infectious demyelination from the history, and very clear typical features both on examination as well as MRI. Was treated with intravenous methylprednisolone 1 gram pulse of 3 days duration. Patient improved. As you can see, this is taken about a month later. The visual field is completely clear. So what is optic neuritis? Optic neuritis is nothing but inflammation of the optic nerve. Now, when the optic disc is involved, we call it papillitis, as I showed you in this case. Sometimes the disc is not involved and it is a retrobulbar portion of the optic nerve which is involved. We call it retrobulbar optic neuritis. Generally, it's a disorder of young people, and there's a preponderance among females. Some important symptoms. This is a picture of the retrobulbar neuritis disc picture where it shows, both the fundi are absolutely normal. There is no disc edema. And then this is a case of optic neuritis with the right eye, which shows a clear-cut disc swelling. It looks like an angry eye. That is what we call papillitis. So what we normally see in a patient who presents with optic neuritis, there's a decrease in the central visual acuity, as we saw centrocecal scotoma. That is on examination, of course, but the patient will report a decrease in visual acuity, and there is generally a pain around the nerve, which is accentuated on eye movements. There is also if one does an Ishihara chart, one will see it's one of the most sensitive tests for optic neuritis. There is a color vision drop, there's severe loss of color and contrast sensitivity. A relative afferent pupillary defect on torchlight examination is usually seen in unilateral cases. Nowadays, we are seeing bilateral also quite often. But in bilateral also, there could be an asymmetric involvement. Flashes of light may be seen. And this is some phenomenon you see in multiple sclerosis, where there's a transient deterioration of vision with heat or exercise. Sometimes there can be a disturbance in the perception of depth of moving objects. It's called the Pulfrich phenomenon. So there is an optic disc swelling usually seen. And visual field loss, like we saw, it could be minimal, like a central or centrocecal scotoma. Sometimes you can get a severe diffuse vision loss, arcuate defects, even altitudinal scotomas, which are more common in ischemic optic neuropathy, but can be seen in optic neuritis as well. If there are retinal exudates, cells in the vitreous, peripapillary hemorrhages, there are other underlying causes such as neuroretinitis, etc., must be thought of. We'll come to the second case. This is a 25-year-old lady who presented with a history of decreased vision in the left eye since 4 days, associated with painful eye movements. So the left eye visual acuity was 6/120. There was an RAPD in the left eye, color vision was impaired. There was a left eye disc edema. And here what we see is an advanced visual loss was seen. As you can see, there is a disc edema in the left eye, very clearly visible. And you can see an advanced visual field loss. The pattern deviation is not even visible here because of the poor visual acuity. And here you can see again diffusion restriction showing a short segment of the optic nerve is involved. Here this shows the contrast enhancement also. And what we are seeing in the brain MRI, we are seeing some demyelinating plaques. As you can see, these white periventricular opacities which are seen. Here, what happened was the patient's NMO-MOG was negative, protein elevation was there slightly, and oligoclonal bands were positive. Patient was again treated with intravenous methylprednisolone pulse, followed by steroid taper. But as here patient met criteria, McDonald's criteria, patient was started on a disease-modifying agent for multiple sclerosis. Patient has been on dimethyl fumarate since 2 years and doing well. So this was, and as you can see, the visual acuity is restored along with the visual field. This is a case of multiple sclerosis. I will share one more case history before we discuss about multiple sclerosis. A 40-year-old lady who presented with a history of decreased vision in the right eye since 4 days, associated with painful eye movements. Again, the visual acuity was decreased and there was an RAPD. Color vision was impaired, 0/21. Right eye disc edema was there. Fields, however, showed only a centrocecal scotoma. This is a disc picture which is showing edema. As you can see, there is a centrocecal scotoma here in the right eye. And there is definitely an enhancement of the optic nerve, which appears brighter on the right side. And there were multiple demyelinating plaques. As you can see here, these are periventricular plaques which are oriented perpendicular to the corpus callosum in a perivenular distribution. And this is what is known as Dawson's fingers. They're ovoid periventricular lesions. And the same patient, as you can see, there is a short segment involvement of the spinal cord. This is less than 1 segment length and less than 50% of the spinal cord diameter. As you can see here, the diameter is also less than 50%. So this patient also, this is taken, it just shows a bearing of blind spot subsequently. The centrocecal scotoma is slowly decreased. It is still there, but it is decreased. And subsequently, the patient became better. Here again, the patient was treated with an IVMP pulse. However, since the patient did not do well with dimethyl fumarate, already had large number of lesions, patient is on rituximab pulse. This is another disease-modifying agent which we use multiple sclerosis. So this is a pattern of optic nerve involvement in I'm sorry, in multiple sclerosis. As you can see, multiple sclerosis usually involves a short segment, and usually it's a mid segment of the optic nerve which is involved. Unlike, we'll come to these patterns a little later. Again, even in the spinal cord, it is classically defined as short transverse myelitis, which is a spinal cord lesion which extends less than 3 vertebral segments. As we saw in that case, it was extending just over 1 segment. And cross-sectional diameter, again, it is less than 50% of the spinal cord area. It can be seen, a lot of overlap is there. Sometimes in NMO spectrum disorders also, you can see a short transverse myelitis. So one must keep a clinical suspicion of all demyelinating disorders in mind. Now, this is the McDonald's criteria for multiple sclerosis. I don't think we need to go over it. Basically, if there are 2 clinical attacks and evidence of 2 lesions, nothing further is required. If there are 2 clinical attacks and only 1 lesion, then you need dissemination in space criteria. 1 clinical attack and 2 lesions, then it will be required dissemination in time. So if 1 and 1 is there, you require dissemination in space or dissemination in time or CSF specific oligoclonal bands. Right. So these are the criteria for dissemination in space. Like I mentioned, we saw a lot of periventricular lesions. You can have juxtacortical, infratentorial, spinal cord also we saw. Dissemination in time, again, I'll not go through this. It's very clearly visible. But one thing one must remember is that in the 2017 McDonald's criteria, anterior optic pathway is actually not a part of the criteria. Now we'll proceed to the next case, which is a 35-year-old lady who presented with a history of weakness of both lower limbs and left upper limb since 1 month. So from the history itself, we can make out that there is a larger segment of neuroaxis involvement. However, patient had a history of blurring of vision both eyes 6 months back, and she was treated with intravenous methylprednisolone and improved partially in the left eye. So the visual acuity, right eye was poor, 6/120. There was a severe field loss. There was bilateral optic atrophy on fundoscopy. Power was impaired in both the upper limbs and lower limbs, and there was a sensory level at C5. So this is showing some sort of a diffuse optic atrophy, especially on the right side. Right side, the field could not be done because of the poor visual acuity. Left side is showing peripheral defects. Now here again, the CSF protein was elevated. However, aquaporin 4 antibody was strongly positive, or the NMO antibody. So we can see here, there is a bilateral optic atrophy. The optic nerves look like strings. And there is a long segment involvement of the spinal cord, extending from C2 to almost C7D1. And there is a on contrast, there is what we call the central spotty sign, which we see in NMO. There is a bright central signal of the spinal cord. So here, patient received methylprednisolone followed by steroid overlap, and as a disease-modifying agent, azathioprine was used. Patient is doing very well on follow-up. Now, before we proceed, just a quick word on what is NMO spectrum disorders. So there are 2 antibodies which were discovered in 70% of patients who presented with these NMO spectrum disorders: anti-aquaporin 4 and anti-myelin oligodendrocyte glycoprotein, MOG antibodies. Aquaporin 4 is a water channel, so it is present in the neuraxis wherever it is close to CSF. So along the surface of the ependyma and the foot processes of the astrocytes, aquaporin 4 is distributed. MOG is present more on oligodendrocytes. So epidemiology, generally, it is present in the mid-age group, around 15 to 30 or 40 years, but you can have less than 15 or more than 60 years also in a small 15 to 20% of cases. Predominantly, it involves ladies. I'll not go into the pathogenesis, but the basic premise is that this antigen NMO is present in the foot processes, and there is a cell-mediated and complement-mediated immunity which results in breakage of the endothelium, damage to the astrocytes, and as a result, support to the neurons is lost. How MOG, which is present on oligodendrocytes, acts, nobody really knows. This is the diagnostic criteria. So we need to know these core clinical characteristics: optic neuritis, myelitis, area postrema syndrome, which is predominantly involvement of the dorsal medulla, brainstem syndrome, symptomatic narcolepsy or acute diencephalic syndrome. I'll later on give examples of all of these. Symptomatic cerebral syndrome. So at least 1 core clinical characteristics with positive aquaporin 4 antibody with exclusion of other diagnosis, good enough for diagnosis. Or you have to have at least 2 if the diagnosis of is without the aquaporin 4 in 30% cases, or unknown status, you need to have two core clinical characteristics resulting from one or more clinical attacks fulfilling, of which at least one of them should be optic neuritis, long transverse myelitis, area postrema syndrome, with dissemination in space characteristics for NMO, and fulfillment of additional MRI requirements. So these are the MRI requirements. One must remember that in the acute optic neuritis, there should be involvement of greater than half the length of the optic nerve, or with optic chiasma involvement. This is unlike what we see in MS. And in acute myelitis, there should be a lesion which is spanning greater than 3 contiguous vertebral segments, or focal cord atrophy with previous history of myelitis. Or it could be an APS, which is an area postrema syndrome, or an acute brainstem syndrome. There are some differences in the profile of patients who suffer from multiple sclerosis and optic neuromyelitis optica. Optic nerve, as in MS, is generally short segment, whereas it's long segment. Same thing with the spinal cord involvement. Brainstem, generally, it can be anywhere in multiple sclerosis, whereas dorsal medulla is very important. Diencephalon is more commonly involved in NMO spectrum disorders. So this is something about, and generally NMO spectrum disorders, because of the larger volume of the neuraxis involved, it results in more severe disorder. So this is the optic nerve findings in NMO spectrum disorders. As we saw, predominantly it's posterior, and it involves the chiasmal and even the retrochiasmal part of the optic nerve. And like we said, this actually shows the distribution of the aquaporin 4 antibodies, and the brain lesions are generally found around this. So this is the area postrema. Then you see along the ventricles, corpus callosum. So these are some areas. This is the diencephalon. But sometimes there can be an overlap with MS also. Spinal cord MRI findings, generally what we see is a long transverse myelitis. And there can be even necrosis, which results in that bright spotty sign that we see. Now we'll go to an 11-year-old child who presented with a history of acute onset, painful blurring of vision since 1 week. Right eye visual acuity was 6/24. There was a RAPD, right eye disc edema. So this is what we saw. There was severe disc edema, typical of papillitis, as you can see in this picture. And there was, I told you can have centrocecal, complete field involvement. Here it's more of an altitudinal, inferior altitudinal scotoma in the right eye. And here you can see that there is a central segment of the optic nerve involved. You can see it's rather a long segment, but it does not involve the chiasma and the retrochiasmal pathway as much. And there is a bit of optic perineuritis also seen in this, which sometimes we see with MOG spectrum disorders. So here the MOG was strongly positive, and the child received 1 gram for 5 days, improved with a steroid overlap, and now is on rituximab pulses, which when we discuss, we give various options. So the parents chose rituximab. It's been 3 years, and so far child has received, I think, almost 4 pulses and no relapses till now. And as you can see, the vision has completely improved. The altitudinal scotoma has completely disappeared. This is a 30-year-old lady who presented with a history of walking associated with numbness in hands and feet. It progressed over 1 day to inability to stand and walk. Then, within 1 more day, she developed sudden blurring of vision. So this is rather a quick involvement of both the spinal cord and vision. So she was conscious, alert. Right eye and the left eye, the bilateral visual acuity was 6/24, bilateral disc edema. Lower limbs were only 2/5, sensory level was 5, C5. And as you can see, there is a lesion here, which is extending over 2 segments. And you can see there's a bilateral optic nerve involvement. There's a flare image. And here again, you are seeing the patchy enhancement of the optic nerve. Emoji antibodies were positive. Patient has been treated with rituximab pulse and is doing very well right now. The power has improved. So anti-MOG disease, involvement of the optic nerve is generally long segment, and it is anterior to mid segment. The posterior portion is not that clearly involved. And very often it can be bilateral. The conus involvement is considered to be highly specific, although it can involve other portions of the optic nerve. And this head-shaped hypersensitivity is a classical feature which we see in MOG-associated disease. Some clinical and differences between aquaporin 4 and anti-MOG. Generally, anti-MOG patients are a little younger. And this simultaneous, as we saw in the previous patient, less than a week, the optic nerve as well as spinal cord involved, and sequential, which happens within a month, is very common. And deep gray matter is not quite often involved in NMO, whereas ADEM, which is seen in younger people and MOG, can be seen very well. And spinal cord is usually cervicodorsal, whereas it is lower cord. And more posterior bilateral and retrochiasmatic involvement of optic nerve is commonly seen in aquaporin 4, whereas in MOG, it's anterior and mid segments. The recovery in MOG is generally a little better than aquaporin 4. We'll proceed to another case, a 34-year-old male who presented with a history of diplopia on looking to the right since 1 week. Now, after this diplopia, he developed excessive sleepiness in the daytime since then. On questioning, he had a decreased appetite with severe nausea and vomiting. Looks like different parts of the brainstem are involved. Sleepiness can be like some feature of narcolepsy, and the patient also looks like he had area postrema involvement because of nausea and vomiting. So clinically, we could find only a right sixth nerve paresis. Otherwise, everything else was normal. But you can see there is a brainstem involvement, which is predominantly involving the pons and extending downwards up to the medulla and extending upwards also into the midbrain. So again, OCBs were not seen in the CSF. MOG was strongly positive. This actually, we saw this case in 2017, and we could do the MOG only around 6 months later, which showed it to be positive. Initially, only NMO was available. Patient was put on rituximab pulse. He did very well. As you can see, the lesion has almost disappeared. 6 months later, this is. And you can see the flare hyperintensities have disappeared from the brainstem. But as many of our patients are, he defaulted and stopped coming after 8 months on the second pulse. And then he developed an optic neuritis with the right eye. You can see, but he came very early. So you can just see that there is a bearing of the blind spot. And you can see there is a diffusion restriction of the right optic nerve. There is a long segment involvement of the right optic nerve. So here we are seeing the spectrum of MOG associated disease. And now he is coming regularly for all the pulses and he's doing very well. So what we have seen is that the clinical syndromes can be unilateral or bilateral optic neuritis in case of NMO spectrum disorders. You can have long segment involvement, transverse myelitis, LETM, area postrema syndrome, diencephalic syndrome, brainstem syndrome, rarely encephalitic syndrome. We have not seen an example of this till now, or rarely cryptogenic leukodystrophy. Sometimes we have seen patients who come with bilateral optic atrophy, which has occurred due to some sort of decrease in vision 2 years back, 3 years back, and we find them to have cryptogenic leukodystrophy all over the brain and positive for NMO. So I'll just present 1 or 2 small cases which shows the actual spectrum of NMO disorders. There's a 4-year-old girl who had progressive weakness of lower limbs since 3 months, was being investigated for an intramedullary tumor. As you can see this, it's a holocord involvement and the cord is actually expanded. But you have the central spotty sign as well, and this turned out to be MOG positive. A 25-year-old girl presented with acute onset confusions in 7 days associated with decreased vision in both eyes. Here you can see there's an ADM-like picture with involvement of optic neuritis. Again, this lady did very well, was MOG positive. Another case of a 32-year-old doctor who had a history of headache and seizures since 3 months was referred for stereotactic biopsy, actually had encephalitic features which were shifting. So this is the second MRI done. The earlier MRI showed on the opposite side. So just before biopsy, a scan was done which showed the shifting and then was MOG positive. So coming to the final approach to optic neuritis, the clinical presentation and unique features which are important for various types of optic neuritis, as we have discussed, have to be considered. A detailed neuro-ophthalmic examination, which includes visual acuity, pupillary examination, fundoscopy, fields, all these things have to be done in great detail. Visual evoked potentials. Then, you know, when we do an MRI, we should always do plane and contrast, brain and orbit with whole spine. A CSF analysis, vasculitic workup, because many of the patients who are positive for NMO very often have associated, up to 20% cases have associated autoimmune disorders, anti-NMO antibodies. So this is just a paper from NIMHANS where 93 cases of MOG was published in Green Journal of Neurology. And they actually said that the poor prognostic indicators was incomplete recovery from an acute attack. If they didn't recover, brainstem syndrome, ADM with incomplete recovery, MRI suggestive of leukodystrophy pattern, severe optic neuritis, and edema. Now, just one quick thing which I wanted to share. We have covered all the different treatments also. But one thing one must remember, especially in NMO spectrum disorders, is the response to methylprednisolone is poor. There is a large body of data that plasmapheresis and rituximab should be used. And we have used it for a few patients. In our experience, we've seen about 65 cases which are seropositive. There are a number of cases which fit into criteria which are seronegative. And 59 patients had unilateral or bilateral optic neuritis. 5 had long segment transverse myelitis. 4 had sequential transverse myelitis with optic neuritis. 1 brainstem area postrema, which we have already seen. 1 encephalitic and 1 EDM. Almost everybody received IVMP. Only 1 patient needed plasmapheresis. 6 are on rituximab and the rest are on azoran. So one must remember that optic neuritis may be due to a post-infectious cause or due to other disorders. Multiple sclerosis can be diagnosed by the distinct constellation of symptoms. A high index of suspicion must be maintained to recognize NMO spectrum disorders. An NMO spectrum disorder is, as the name suggests, not only optic neuritis and myelitis, but has a spectrum of involvement like area postrema, brainstem, diencephalic, cerebral syndromes, and it may be comorbid with a number of collagen vascular disorders. This is our neurosciences team. And a special mention must be made of Dr. Sharath, who has been instrumental in helping us decipher these cases and always very helpful with helping us out with the diagnosis. And this is our neuro-ophthalmology team headed by Professor Rohit Shetty from Narayan Nethralaya, who is a vice chairman and who has been the vision behind the neuro-ophthalmology clinic. Dr. Abdul Rauf, of course, we will be hearing shortly. And then we have Dr. Chaitra and Dr. Purna Chandra as well. I'll leave you with Winston Churchill's famous words that it is the courage to continue that counts. Thank you.
Thank you, Dr. Sujit. Wonderful presentation. It's very nice that you have taken a case-based approach. That was very interesting and educative. Thank you very much. Now, what we will do is we'll go back to Dr. Abdul Rauf's presentation so that he can complete the presentation. Then we'll take up the cases, questions. Sorry.
Am I audible now?
Yes, sir, you're audible. Please continue.
Audible. I'll share my screen now. So I'll carry on from where I left, or shall I start again?
Not necessary, Dr. Abdul. You can continue from where you left.
Yeah. So I had stopped at the moment we see bilateral optic disc edema, we should, first thing is check the blood pressure. And I've seen quite a few cases of very high BP being detected. So usually the difference is you don't see so many flame-shaped hemorrhages or cotton wool spots when you see a raised ICP, intracranial pressure. In malignant hypertension, you would see these soft cotton wool spots and hemorrhages and arteriolar narrowing and AV crossing changes. And as you see these exudates, so it's very typical of grade 4 hypertensive. This is another patient, but with less hemorrhage. So either way, it would be better to check the blood pressure always when you see a patient with papillary edema. So what do we do when you have a grade 4 hypertensive retinopathy? If it's high, immediately refer to a consultant physician or internist, a cardiologist if required. Do a fundus photography, a visual fields, blood tests like complete hemogram, ESR, CRP, creatinine, a lipid profile, FBS, HbA1c, homocysteine, urine analysis for microalbuminuria. In a young patient, most often they are young, these patients. Systemic vasculitis work, ECG, echocardiography, MRI brain and orbit plane is always useful, and always check if the creatinine is high, better to avoid contrast. Repeat visual fields regularly if required, because anterior ischemic optic neuropathy is a possible complication. If the creatinine is high, refer to a nephrologist. We should not stay quiet. Ask the patient to consult regarding his diet, his or her diet. Ask the patient to stop smoking and stop alcohol. these are some things we can do when moment we see as a moment we see a hypertensive, grade 4 hypertensive retinopathy. And coming to pseudo papilledema, pseudo disc edema, the history as I've gone through before papilledema, the symptoms are very classical. And here you have hyaline-like calcified deposits in the optic nerve head. So they may be superficial or below the disc surface. So we have two options. Generally, B-scan ultrasound is a fantastic machine to piece of equipment to detect the papilledema. You show the increased subarachnoid fluid. You see the crescent sign or the donut sign, the positive 30-degree test. I'll be coming to that a little later. And then, of course, the MRI showing prominent perioptic spaces. And there will not be spontaneous venous pulsations. So the moment spontaneous venous pulsations are there, it's not raised intracranial pressure. So whereas in a pseudodisc edema, you see a hyperreflective bright area on the optic nerve head, which persists at low gain. And FAF is fundus autofluorescence. So here, this is a papilledema, patient with papilledema, raised intracranial pressure. And this is a pseudodisc edema. If you see here, blood vessels are all obscured on the disc, whereas here they're relatively seen. So this is one clear differentiating factor. And then if you look carefully, you may see a lumpy appearance on the disc. A fundus autofluorescence will help if the drusen are on the surface, but if it's deeper, it may not help that much. This is again a pseudodisc edema. Again, here you see the blood vessels are quite clearly seen. And on the ultrasound, you can see the hyperreflective area on the lower part and highly reflective spike on the A scan. That is the one below, the wave below. And the arrow pointing is on the B scan. So even if you reduce the gain, the drusen is still visible. On top right corner, you're seeing the diameter of the optic nerve, which is normal in this case. Normal is 2.2 to 3.3 millimeters. And this is the other eye. So usually they're present bilaterally, though sometimes there may be one eye with visible drusen, so obvious that it's disc edema, the other with very mild disc edema. It can be asymmetric. This is the crescent sign, what we see. If this optic nerve you see is a round shadow, echolucent and echo-free shadow. And around that, you see the crescent. That is the fluid around the optic nerve. So this helps us in diagnosing papilledema very easily, actually. And below you have the diameter of the optic nerve, which you can measure on the A scan. So it should not be measured on the B scan because it's not accurate. So A scan is much more accurate. Another thing is myelinated nerve fibers. This is quite obvious. You don't have to, there's nothing much, but as a DD for, this is a DD for optic disc edema. So this is very clearly seen. You see the myelin normally stops short at the optic disc behind the globe. So when it extends into the, beyond the from plate, you see this appearance. And it can give rise to such field defects. So this is a normal thing when you see a myelinated nerve fiber. These field defects are normal in the temporal field, especially. So what do we do in bilateral disc edema? Standard 30-2 threshold. So we should not ask for a 24-2 or 24 degree. That means a 30-2 is a 30-degree field. And a Humphreys field analyzer is the best, a CETA standard. So there is CETA fast, CETA standard, and the screening test. You should never do a screening test. You should always do a CETA standard. And a 30-degree test is ideal. 60 degrees is not required. In cases of maybe cellular tumors, a 60 degree may be used. A B-scan ultrasound of the optic nerve for increased subarachnoid fluid. Always document with photography and OCT. MRI brain in orbit, always a plane and contrast study. MRV brain, when once you rule out any space-occupying lesions and you're suspecting idiopathic intracranial hypertension or cerebral venous thrombosis. LP manometry once IH is confirmed, and CSF analysis and neurologist consultation is mandatory. I don't think there are many neuro-ophthalmologists, but I think none of them should handle the patient except a neurologist. I firmly believe this. So, and among the causes of raised intracranial pressure, idiopathic intracranial hypertension is the most common. You should remember that It's 9 out of 10 are women of childbearing age, 20 to 45 years, and they may be obese. Most of them are obese. There's another grading of papilledema, the Friesen scale. Although this ultimately comes down to, whatever we say, whether it is stage 1, 2, the question is there papilledema or no? That is important. This, the appearance wise, it may grade it as stage 1, 2, 3, 4, or 5. But I don't think clinically, at the end of the day, it matters whether there is papilledema or no. And this is an older classification where we have early, established, chronic, and atrophic. So what is the importance of fundus photography? One is documentation, explaining to the patient about the condition. Because the patient, so many times the patient comes to us and it may be an incidental finding, optic disc edema. It's easy to compare at follow-up. Supposing you should take a photograph when the patient comes in the beginning, so that at the 3rd or 4th visit, you know what is the reduction in disc edema, teaching purposes and publication. So in early papilledema, we have a mild blurring of disc margins, and you look for the spontaneous venous pulsations. They are usually absent in about 20%, but when present, when it is not there, you have optic disc edema, that is one indicator that the pressure is raised. If the spontaneous venous pulsation is there, then that it means that the intracranial pressure is normal. This is an early disc edema. What you're seeing is early papilledema. And when you have established, there is severe hyperemia. There's an elevated disc, the cup is obliterated, the blood vessels are obscured. You may find cottonwool spots are not very common, flame-shaped peripapillary. Just around the disc, you'll see hemorrhages. Unlike in grade 4 hypertensive retinopathy, where you find it all scattered. And patterns lines, retinal folds, which is circumferential to the disc, and a macular fan may be visible. This is an established papilledema. Again, one more case of established papilledema. This was a case of fulminant IH with a rapid visual loss. So you can have rare cases like this. Chronic papilledema, usually there will be some gross field defect. The disc is elevated, hemorrhages are no longer present, blood vessels are obscured, and you see corporatia, amylacia. These are crystalline drusen-like deposits. This is what you see, the yellow ones, small spots. This is in a case of glioblastoma multiforme. This is a patient who lost his vision and he came towards the end. This is a case of, again, a chronic papilledema. You see the whitish appearance starting. And the last stage would be atrophic papilledema. Vision is severely impaired. There's gross optic atrophy visible. It appears grayish white, and only you will see gross arteriolar narrowing, as you see here. It's a case of atrophic papilledema. So what complications could occur? You can have a visual loss, a secondary vein occlusion from papilledema, a disc infarction. If patient has associated hypertension or anemia, these are other causes, risk factors for visual loss. And another case here where what we should keep in mind, this is a case of bilateral optic disc edema. Now it would appear like raised intracranial pressure, but this is a case of BKH syndrome, Vogt-Koyanagi-Harada syndrome. Now here, the patient's symptom, that's why a history is very crucial. Patient would have presented with floaters, and when you look at the retina, you will have seen multiple serous retinal detachments. So unless we dilate the retina and see, this would appear like a normal papilledema, what we see. So it can be mistaken for a papilledema, but the symptoms will be absent. So this is important. One is to ask for floaters. So you see the on FFA, that pinpoint fluorescence, which later progresses to diffuse leakage, pooling of the dye. And this is, you see the detachment, the macular area, what you're seeing there. So again, just another important is what to do, visual fields. Once you do the fundus photography of visual field, in raised ICP, the earliest change you see is an enlarged blind spot. Later, you would find an arcuate defect or inferior defect or a central scotoma, centrocecal. In the end stage, you would see a constricted field. So this is, as the red arrow points out, is an enlarged blind spot. So this is what we call a pattern deviation towards the right hand where the arrow is. So you should always look, you should not look for the top right side where you have the gray scale, the field, that is for the patient basically. the interpretation would be on this side, the pattern deviation. Here again, you see enlarged blind spot in both eyes with bilateral papilledema. And this is a case of visual field constriction in case of papilledema. This is a case of tuberculous meningitis with papilledema. You're seeing asymmetrical involvement of the optic nerve. And if you see the patient was treated and a few weeks later, the patient improved in the right eye, whereas you're seeing a classical enlarged blind spot in the left eye. And this is a centrocecal scotoma in both eyes. So B scan is very useful to detect B scan along with an A scan. It comes together. So useful to detect increased subarachnoid fluid, optic nerve thickening, and to differentiate it from drusen. The crescent sign or another sign is a donut. So you include a double crescent, one on this side and that side, that makes it a donut. But basically you're looking for whether the optic nerve diameter is increased or no. Greater than 3.3 is significant, but 3.4 also is not too significant. It usually in papilledema, it will be something like 3.8, 4 to anywhere between 6, 6.5 to. And there's a 30-degree test. When the patient looks towards the probe, there's a 15% reduction in 10 to 15% reduction in the size of in the measurement of the optic nerve diameter. This is the classical crescent sign, what I said, arrow pointing towards the fluid, increased subarachnoid fluid. And obviously you see the disc elevation in front on ultrasound. They're very useful. Then we go to what is the next step we do is in case of IIH, idiopathic intracranial hypertension, after excluding a space occupying lesion, lumbar puncture, normal, we do LP opening pressure manometry, normal is 12 to 18 centimeters water. So, and we do a CSF analysis, which is standard. Neuroimaging, always we do MRI brain and orbit, brain and contrast, and what we see classically thickened tortuous optic nerves, kinking of the optic nerve, widened perioptic spaces, an empty cella sign, and MRV brain should always be asked unless there's a space occupying lesion. MRV brain is always asked, and you would see transverse sinus stenosis, and you could rule out cerebral venous sinus thrombosis. Here you see papilledema. On the left, you see raised intracranial pressure, patient with papilledema, and you see kinking of the optic nerve and thickened perioptic spaces. And this is the empty cella, and not so classical transverse sinus stenosis, but there was in this. So here, empty cella is very typical. So, and we should keep in mind modified Dandy's criteria to diagnose IIH. So these are the criteria: signs and symptoms of raised ICP, absence of localized neurological signs except 6th nerve palsy, LP manometry greater than 200 millimeters water, absence of deformity, displacement or obstruction of the ventricular system, no other causes of raised ICP. And management would include advising weight reduction. Medical management includes oral acetazolamide or furosemide, oral glycerol sometimes, and surgical management. The carbonic anhydrase inhibitor acetazolamide is used most often. Sometimes spironolactone and furosemide may be added. There's no role for long-term use of steroids. If non-pharmacological treatment is considered, a LP shunt or a VP shunt is most common. And if severe visual, impending visual loss is there, optic nerve fenestration may be tried. Those are the older, I think, gastric reduction surgeries. These are all additional. A neurologist is the most important person here. He or she does everything here. So I don't think the neuro-ophthalmologist as such, we just add to the diagnosis and we help in the management. But the main, I think, without a neurologist, nothing works. And a neurosurgeon must for any sort of surgery. And what we do is you should do a periodic visual acuity, color vision, and visual field, and fundus examination, and ideally a monthly follow-up for 6 months with these things. Patients sometimes do not agree, so we do it for about 3 or 4 months, and then do it 2 monthly till you stop treatment. And differential diagnosis again is cerebral venous thrombosis with raised ICP and papilledema. This was the patient. This is a patient with papilledema, and this was a case of cerebral venous thrombosis. As you see, the little enlarged blind spot on the right eye, right side. This is increased subarachnoid fluid on ultrasound, thickened perioptic spaces on MRI, and you have thrombosis of the right transverse sinus, sigmoid sinus, internal jugular. So cerebral, I'm not going into the detail. This is not my area actually, but just to add to the notes, it is anticoagulation or thrombolytic therapy with heparin, enoxaparin, warfarin, or thrombolytics. These are the ones we use. And another patient who came to us was, this again looks like edema. It is optic disc edema. So I too was very confident. That's why we should never be overconfident. Until the fields was normal, nothing was there. And so I thought it was papilledema due to IH. Patient had headache. And when you see as a large ethmoidal mucocele with compressing, you see it goes compressing even on the left side. So not only on the right, of course, it's compressing, but it is enlarging more even towards the left. If you see the picture on the right. So ultimately, the patient had to go to the ENT surgeon, and he did well after surgery. He improved completely, and vision recovered, the disc edema recovered. So sometimes you may face a situation where you have ischemic optic neuropathy where it has occurred in one eye. Usually ischemic optic neuropathy does not occur in both eyes, but you can have one occurring at one time and maybe 2 weeks later or 3 weeks later followed in the other eye. So you might have to differentiate from papilledema. Most important thing is, one is patient have associated diseases, diabetes mellitus and hypertension, and the age group. And ultrasound is very crucial, and MRI and MRV gives you the diagnosis. The age of NaON would be 50 to 70 years, and a classical, again, what do you do when you have such a thing? And you have an altitudinal field defect, which is classical in ischemic optic, anterior non-arteritic anterior ischemic optic neuropathy. What do we do whenever we have an anterior ischemic optic neuropathy? One is fundus photography, again, visual fields. Always in neurological fields is a 30-degree field and a CETA standard. CETA is Swedish Interactive Threshold Algorithm. So it is understood. So on the Humphrey field analyzer, there are quite a few analyzers. The gold standard is Humphrey's. So we should always ask for a CETA standard threshold. So because there is something called a CETA fast, a quicker test, and there's a screening test. So it should always be a 30 degrees, and there's a 24 degrees. 24 degrees is more useful for glaucoma. And then appropriate blood test, carotid and vertebral Doppler, neuroimaging, MRI, brain and orbit with contrast, and always with the neurologist. This is what I said. You have one NaON. The left eye also started developing an ischemic optic neuropathy. So it might mimic, but generally it is sectoral, or there'll be some flame-shaped hemorrhages. But this gives you the diagnosis. So an altitudinal scotoma, this can occur in one eye or in both eyes. It can be quadrantic, but it will be either inferior altitudinal or superior altitudinal. And what tests do we do in NaON? One is blood pressure, ask for a sugars, FBS, HbA1c, ppBS, lipid profile, serum creatinine, again look for microalbuminuria, complete hemogram, look for anemia, type of anemia, ESR, CRP, which helps you differentiate from arteritic type, hypohomocystinemia, do a sleep study, ask for obstructive sleep apnea, smoking, use of erectile dysfunction, use of Viagra, amiodarone, coagulopathies. If you suspect coagulopathies, a procoagulant workup, carotid and vertebral Doppler, and MRI last. So any case of optic disc edema, we generally do a MRI. Treatment, again, you treat the systemic factors. Antithrombotic, we use double platelets or double antiplatelets or single. Most often it's aspirin. Systemic corticosteroids, we use steroids, though some may be against it, but under a physician's guidance, we can always go ahead with the steroids. Intravitreal and optic nerve sheath is a no-no. When you treat NA, always be careful. I think whenever you see an ischemic optic neuropathy, be careful in administering the drug at night. Antihypertensive drug to preferably be shifted to 5 to 6 o'clock. say instead of 10 o'clock. Because nocturnal hypotension is one of the main causes. The hypoperfusion of the optic disc head is the cause of NAON, the currently running theory actually. So you have a history of NAON, giant cell arteritis, a normal tension glaucoma, or internal carotid artery occlusion, chronic optic disc edema. You should be very careful when you're giving the antihypertensive drug at night. An MRI or an MRA may be required, as in this case when we happened to ask for it when it was optic atrophy had set in the left eye, found an internal carotid artery occlusion. You see, it was absent on the right side. And when do you check for prothrombotic factor? I have still to see a bilateral simultaneous ischemic optic neuropathy, but recurrent we have seen, familial I have yet to see. The other thing, you have clotting factors. So if you have NAON occurring in a very young patient, we have altitudinal type of, and it comes negative for optic neuritis, and you have bilateral simultaneous NAON, recurrent NAON, then you should do the prothrombotic factors. Now, the other differential diagnosis, how would you differentiate between bilateral papillitis? Usually, the vision is normal in papilledema. You have a sudden visual loss here in papillitis. So optic neuritis may be a retrobulbar neuritis, optic neuritis, papillitis, or a neuroretinitis. We are generally concerned with papillitis because it shows optic disc edema. And patient will present with some fever, hemicranial headache, eye pain, painful eye movements. There's a mild vitreous haze, field defects, any sort of field defects. So in early papilledema, you'll never get a field defect. Whereas in papillitis, optic neuritis, you will always get a field defect. And contrast MRI is a must. And again, as I said, ultrasound, I generally don't, the field gives you the diagnosis in papillitis. LP for CSF analysis, and the treatment is different. Here you do LP manometry, and there you do LP CSF analysis and a vasculitis workup if required. What do you do? Again, a visual fields 30-2, an optic disc photo, blood tests. Dr. Sujit has gone into it. MRI brain and orbit with contrast, MRI whole spine, LP for CSF analysis, oligoclonal bands, VEP, OCT on a follow-up basis. CT has no role generally in optic neuritis. And this is a case of bilateral optic neuritis, which can be confused for again a case of bilateral optic neuritis. So on top, you're seeing a papilledema, lower, you're seeing a unilateral disc edema actually. That is papillitis. This is a neuroretinitis. Neuroretinitis classically, as you see on the right side, you see multiple small dots. These are hard exudates. These are macular. This is called a macular fan. So when you see a macular fan, then you check for infectious causes, generally these cases. But a macular fan, not classical of neuroretinitis, but the field loss is not so massive as in a optic papillitis or in any compressive neuropathy. Here you get generally a centrocecal scotoma. So here is a case of, you're seeing a centrocecal scotoma. Different field effects you see in optic neuritis is right eye, you're seeing a centrocecal scotoma. So a field effect may be anything in a papillitis. There's no specific pattern for optic neuritis. It may be inferior altitudinal, it may be a quadrantic, it may be 3-quadrant, as in the left eye here, it's bilateral. Left eye showing a 3-quadrant effect and the right eye showing a temporal field effect. Again, bilateral optic neuritis, left eye, no particular pattern, right eye and advanced field loss. Here, both eyes advanced field loss. So the difference between papilledema versus bilateral papillitis. MRI really helps because here you find thickened perioptic spaces. Here you have contrast enhancement. So you're seeing the whole optic nerve enhancing on contrast in bilateral. So investigations would include complete blood count, ESR, CRP. We do an NMO MOG antibody testing in all optic neuritis. At least we do it, but because and especially when you have bilateral involvement, it must be done, or chiasmal involvement. Antinuclear, ANA profile, ANCA, CNP, ANCA, Lyme titers, ACE, chest radiography, chest X-ray, quantiferon TB, FTA antibody, FTA test, VDRL, HIV, and when you have a centrocecal scotoma, always good to do a B12 and homocysteine and folate levels. Two important conditions, multiple sclerosis and neuromyelitis optica. I'm not going to go more into this. These are demyelinating lesions, what we see. the Dawson's fingers you're seeing on flare. And Dr. Sujit, as he has mentioned before, revised McDonald criteria. I'm not going to go into detail, and all of you, I think my neurologists will be knowing about this. And NMIST diagnostic criteria, Dr. Sujit just mentioned, optic neuritis, the core criteria, acute myelitis area postrema, acute brainstem syndrome, acute diencephalic syndrome, and symptomatic cerebral syndrome. The characteristic features are NMO lesions, they tend to be longitudinally extensive, involve at least 3 optic nerve segments, and multiple sclerosis tend to be focal. You get more than 4 centimeters in length, 40 mm in length, and if the chiasm and tract can be affected too in NMO, but not in MS usually. So these are some differentiating factors. Sorry. So this is a case of bilateral optic neuritis in neuromyelitis optica. So you should diagnostic criteria for NMOSD. When you have an aquaporin antibody positive, should be 1 core clinical characteristic, and when you don't have, you need 2 core clinical characteristics, and 1 must be optic neuritis, transverse myelitis, or area postrema. And transverse myelitis includes 3 contiguous segments. And this is a MRI brain and a spine showing D2 hyperintense intense signal C2 to D2. And you have flare hyperintense lesions in thalamus and the midbrain in NMOSD. NMO treatment, we give IV methylprednisolone for 5 consecutive days or plasma exchange if it fails. And first-line therapy post-steroids would include azathioprine or rituximab, intravenous immunoglobulin, second-line mycophenolate, mitoxantrone, methotrexate, third-line tocilizumab. And the others would include a combination. So we use most often, I think for us, what has worked, azathioprine and rituximab has worked wonderfully well. And Dr. Sujit is doing a fantastic job in this. Neuroretinitis, you have 3 broad categories: idiopathic, associated with infection, and non-inflammatory, like sarcoidosis or polyarthritis nodosa. Bartonella cat scratch fever is very rare, what we see. Then other causes, mycoplasma, syphilis, tuberculosis. You might have an adjacent orbital disease, adjacent meningitis. It may be in sinus diseases in the orbit, so spreading to the orbit in immunosuppressed. So these are the other causes. I think I'll stop here. Thank you so much for giving me this opportunity. I thank everybody, whoever is in the society. I would thank them. And I'm extremely grateful that you called me and given me a chance to talk on this occasion. Thank you.
Thank you, Dr. Abdul, for a very comprehensive presentation and very beautiful illustrations covering the entire spectrum of the retinal changes. Thank you very much for that.
Thank you, sir.
Dr. Guru, you have to tell me how much time we have. I think just...
now we are at 8:43, so we have around 15 minutes.
That should be fine. There's only one question from the audience, but I have few topics to discuss, some clinically relevant topics. So you can see the question. The first one, I think, is Dr. Vishwanath.
Asked, I think Dr. Vishwanathan can take this. Why convergence not impaired in INO?
Well, it's not that convergence is not impaired in INO. It may be impaired in certain forms of INO when the MLF is involved rostral in the midbrain, where the convergence pathways are found in the rostral midbrain. So there are 2 types of INO, like the posterior and anterior INO. They're little outdated terms. So it is not unusual for us to find an impaired convergence even in INO. So it's not that it always has to be present. Usually because it is present because the conventional area where INO occurs is somewhere in the pons, just above the PPRF. But if it happens very rostrally near the midbrain, convergence can be impaired.
There is one more question. It's not a question, it's a comment. Thank you. It's an excellent webinar, they said. Now, my points are open for all the speakers. So the first thing I wanted to know is, have you seen paraneoplastic optic neuritis, optic neuropathies? What is your, you had 65 cases, it's a good number. You have any experience with paraneoplastic syndrome presenting as optic neuropathies?
Yes, sir. We have seen very few, maybe one or two cases only. We have seen paraneoplastic syndrome. We've also seen optic nerve infiltration with the tumor also. Both we have seen, sir.
Can you tell us about which antibodies and how to suspect these cases? Do you do workup in all cases, or how do you do that?
Well, sir, the treatment will be the primary, as well as we have to treat with immunosuppression, which is what we have done with methylprednisolone. We haven't found any, as in specific antibody, I don't think we have found, but we have found the two cases that we saw were with gynecological malignancies.
But
One was a lung.
Why did you investigate for paraneoplastic? What made you suspect?
No, sir, in both the cases, the patient had already a pre-existing cancerous syndrome.
Right.
So we have not seen, as in paraneoplastic predating, which is described actually, that we have not seen, sir. Predating the onset of cancer.
Yeah, in the literature they say beyond 50 years you suspect this paraneoplastic, and CRMP5 is the one which is related to that, but I have never seen. I don't know, other speakers can comment.
We have done, we do the paraneoplastic workup in those patients where we suspect, sir, wherein we don't have a very clear-cut cause. But so far we have not found any, I think Abdul sir can also answer this, but we have not found any case where there was no primary and we found autoimmune optic neuropathy.
Okay. Then regarding the treatment of optic neuritis, I think a lot of practical things we need to discuss. Earlier, we used to give methylprednisolone as a blanket treatment for all optic neuritis. Now the treatment paradigms are changing, isn't it? In some cases, you have to select plasma exchange initially, early in the course. Can you throw some light on when to give this plasma exchange early instead of pushing more and more steroids?
Sir, most of the patients, I mean, at least whatever cases we have seen, 90% will respond to steroids. 3 to 5 days, 1 gram pulse dose. There are those whose the field doesn't recover. The visual acuity doesn't improve despite 2 weeks of steroids. And we have seen in some patients, we give the pulse, there's a transient improvement. Then after a week or so, the visual acuity decreases. In fact, one patient, while on oral steroids, high dose itself, the patient's vision deteriorated. We repeated the methylprednisolone pulse. It improved transiently, but not fully. And then we had to give plasmapheresis. So the initial treatment, we always give methylprednisolone because practical considerations so that majority of the patients respond. But in those in whom the visual acuity does not respond, then obviously I think we are dealing with probably more of an NMO spectrum disorder or something, even if it is negative serologically, 70% are only positive. So then we give plasmapheresis as a first choice. And once we complete the cycle of plasmapheresis maintenance, I usually prefer to give rituximab and not plasmapheresis.
How long do you wait for steroid response? You give a pulse of 5 days, and how long do you wait?
I think we can wait up to 2 weeks, sir.
Yeah.
In our cases, even after 2 weeks, when we have employed plasmapheresis, there has been a good response.
Any experience with IVIG?
I have never used IVIG, sir.
Okay. Literature
Always, literature is there, sir. I agree, sir.
It's in favor of plasma exchange. Though there are some problems with the trial design, there's a plasma exchange is the preferred mode. So.
Yes, there's more literature on plasma exchange. I've never used IVIG.
What about oral steroids?
Oral only we have used as bridging therapy, sir. So say we have seen about 65 cases, or maybe I think more than 50 cases are on azathioprine only, sir. We give a 3-month overlap with steroids, 30 to 40 mg, and build up on the azathioprine and gradually withdraw over the next 2 months. So 3 to 5 months patients are on oral steroids while the azathioprine kicks in, sir.
As an acute therapy in place of methylprednisolone?
Acute therapy I have never used, so after pulse only we have used, sir. Okay. There is no recommendation, no, sir.
No, there is a ONTT2 optic neuritis treatment trial, second phase of the study. There they found it is equivalent. Oral and IV methylprednisolone are equivalent. Only thing, the Visolin should not be used in this usual 1 mg per kg. It should be 1.5 or equivalent doses of methylprednisolone. It is as good as IV methylprednisolone. Even ACTH is approved In place of methylprednisolone, you can use ACTH. If that is not possible, even oral can be used. That is the current understanding, but at a much higher dose than the 1 mg per kg as an acute therapy. Of course, maintenance we continue, gradual taper.
Never had the courage to try that.
True, true.
And I have a question. Can I make a comment? Wonderful talks, Dr. Vishnathan, Dr. Rauf, and Dr. Sujit. And I also want to, thank Sujit for coordinating this webinar. He is the main brainchild behind this thing. Fantastic here to Dr. Rauf about talking about the systemic causes. We had one patient, my ophthalmology colleague, Dr. Sangeeta, is also on the panel, and Dr. Mayank is my colleague in neurology. He's also there. So we recently managed a patient who had a non-arthritic anterior ischemic optic neuropathy. Lady who had, I think, ITP. I think she had chronic ITP on medications, had this acute onset vision loss. Initially, there was doubt about what is the reason. So very good point he told about sleep apnea and nocturnal hypotension and all. So this lady had, I think, if I'm not mistaken, 6 months back, she probably had hypoglycemia. She was diabetic, and she was getting into hypoglycemia. That probably also can be worsening, can lead to this type of situations. Do you have any experience or not, Dr. Rauf? And also I wanted to ask about how do you use this ancillary test about the OCT and the B scan? Do you use it routinely for IH patients? How frequently do you use this for follow-up on follow-up and all?
Yeah, the visual fields, we would use it regularly, sir. Say, I think first 3 months, generally patients don't agree. Ideally, it is monthly for 6 months, but they don't agree generally due to the cost. So we can do it for about monthly once for about first 3 months, and then every 2 or 3 months for 2 times for 2 months, and then every 3, at minimum at least 3 months. I think till the end, you should go with the visual fields. Ultrasound at the beginning, I do in every case of bilateral optic disc edema, I do. Unilateral, see, what happens is when the patient does not present with a sudden visual loss, and the vision is fairly good, your color vision is fairly good, I go for a B scan. So that gives me a clue that there is something else that made me a compressive optic neuropathy. Because when I do the fields, I'll generally get, if it's an optic neuritis, I'll have a field effect. If it's ischemic optic neuropathy, I'll have a field effect. But when it's compressive neuropathy, again, I'll have a field effect. But if it is asymmetrical papillary edema, I have seen cases where one eye very minimal blurring, one eye gross papillary edema, and it has turned out to be IIH. So such cases, this ultrasound is extremely useful. And it straight away gives you the diagnosis in a false pseudo-disc edema. The drusen is so classically seen, you don't have to do anything because there is also fundus autofluorescence, but you don't get buried drusen. The buried drusen are picked up on ultrasound very easily. So I think that's a fantastic thing, especially for IIH, raised ICP, any cause of raised ICP. And generally, you don't get a field loss in the initial stages in any raised ICP, unless it is a gross injury or something that, say, trauma to the head with traumatic optic neuropathy is associated. Very rare we see such things. So when a patient presents, and I think neurology generally is a lot, you should take a detailed history, because without history, I think we cannot go anywhere in neurology. Generally, if there's a set of symptoms which are so classical for IH, set of symptoms for optic neuritis, ischemic optic neuropathy, usually the patient in ischemic optic neuropathy will get up in the morning and say that sudden loss of vision when they wake up because of nocturnal hypotension. And as you said, sir, diabetic hypoglycemia, these are known, diabetes, all are at risk actually. Any diabetic patient is at risk because they say diabetic papillopathy. So again, what gives it away is diabetic papillopathy, you might have both sides. Now it is called incipient or impending NA1, this diabetic papillopathy. So initially the patient may have disc edema. So we don't do anything there. We just wait for the field. If the field worsens or something worsens, then we go intervene. Otherwise, we would never intervene in a disc edema. So again, the ultrasound will give you in optic neuritis or an ischemic optic neuropathy, The diameter may be slightly enlarged, but you'll never find this crescent sign or donut sign, these two things. So for me, it gives me the immediate diagnosis that, and I don't repeat the ultrasound. I do it towards the end, when just before stopping diamox. Supposing raised ICP, you're planning after a year or planning after 6 to 8 months. Just before that, if the fluid is still there, so we continue for another 2 months of diamox. And then usually most of them, 98% of them resolve.
What about OCT, Dr. Roof?
OCT on a follow-up for optic neuritis, yes, sir. If it is, say, if my personal opinion is, OCT agreed. They say that it is helpful in monitoring multiple sclerosis, neuromyelitis optica, the amount of damage. But one major drawback is patient compliance. That is, they should agree to do. Because altogether, supposing you do 3 tests together or 2 tests together, they won't agree to pay one. OCT is useful in those cases. Ischemic optic neuropathy, I don't think it plays a role, OCT. However, angio OCT is coming in. So it's called OCT angio, where you have, it is replacing, almost sort of replacing the fluorescent angiography. But the disadvantage there is you're looking at the surface capillaries. You're looking at the surface vasculature of the retina. Whereas the pathology is in the pre-laminar, laminar, post-laminar area, which is supplied by the short posterior ciliary arteries, which in turn with the long posterior ciliary arteries. So when you have that, you cannot image, the choroid is not so classically seen very well on OCT angio. So the classical OCT I generally use for, it's very useful in when you have mild temporal pallor. You say early temporal pallor, sectoral pallor, whether it is worsening or no. So you have a standard amount of the ganglion cell complex and the IPL. So the ganglion cell complex, the ganglion cell layer and the inner plexiform layer, that complex thickness along with the RNFL thickness. So that helps you progression, helps you to tell, because if a patient with optic neuritis is progressing, if it's a recurrent optic neuritis, you'll find a gross field defect. Usually in glaucoma, you'll find small amount of increase in field defects, where the OCT is very useful in monitoring the progression. But I don't think we don't see optic neuritis progressing very gradually or something. But it is known to, like a case of multiple sclerosis, yes, OCT is useful. OCT and in neuromyelitis optica, supposing the patient is quiet, you can repeat an OCT once in 6 months, at least. Any optic neuritis, I think once in 6 months, an OCT and a field is mandatory. If the patient is steady, I think yearly follow-up must be done. But as long as the patient is on treatment, I think minimum would be a 6-month field and OCT.
Dr. Shivkumar has asked this question. How do you differentiate between AION and optic neuritis in a young patient without vascular risk factors?
Anterior ischemic optic neuropathy in young, usually you don't get anterior ischemic optic neuropathy. AION, now you have arthritic and non-arthritic. So if it is non-arthritic, it is generally above 50 years. So, and there will be predisposing factors like, as I said, diabetes, hypertension, hyperlipidemia, homocystinemia, coagulopathies, anemia, a host of causes, cardiac disease, kidney disease, chronic kidney disease. These are the histories which you will be taking. Optic neuritis is the patient presents in a young, it presents in the young. You don't get AON in young. Very, very rare. That's what I said. Bilateral NaON in young is very rare. Now coming to arthritic, there is a possibility where we have arthritic is not only temporal arthritis. So we don't have, it's not only giant cell arthritis. So we have vasculitis, the causes, you have collagen vascular diseases as causes of arthritic type of AON. I have seen it, but it is extremely rare. The field would give you an idea. Generally, the field defect. because why you get these field effects, you have this watershed zone, because the pathology between anterior ischemic optic non-arthritic is totally different. It is hypotension at the optic nerve head, hypoperfusion, sorry, of the optic nerve head. And in arthritic type, it is an occlusion of the arteries, short posterior ciliary arteries or the long posterior ciliary arteries. Non-arthritic is extremely, extremely rare, and I've never seen it in a young person. Non-arthritic, even I do not know why, but even in a diabetic. So the other thing what we look at is, you look for a disc at risk. When you see in a young patient, where you look for a small disc, a disc without a cup, 0.1 cup, 0.2 cup. These are prone for non-arthritic. Non-arthritic, usually it will be an optic neuritis in a young patient. If it has to be, you have to look into vasculitis, systemic vasculitis. You have to do a thorough workup for that. And in case all of that is negative, I think a prothrombotic profile is worth it in a young patient. If you feel that there's no optic neuritis, it's not responding to steroids, I think you should look at a MR angio, do an angio instead of a Doppler, and do a complete systemic vasculitis workup and do a prothrombotic profile. And in optic neuritis in a young patient, generally patient present with pain. So 3-4 things: sudden loss of vision, a fever, preceding fever, painful eye movements, headache. If it's one-sided, it will be a hemicranial headache, otherwise the frontal headache, eye pain, painful eye movements. Another thing what you can do is just ask the patient to look down and just palpate the globe on the top. Just touch with one finger. At some point, they will give tenderness. So these are some signs, subtle signs, and the field will generally give it away if it's an optic neuritis. And I think always, unless there's a contraindication, contrast MRI. Contrast MRI will easily show optic. So one is diffusion restriction, what we see on MRI of the optic nerve. Second is contrast enhancement. These two things I have generally seen.
There is one more question, Dr. Guru, if you read out the question.
66.
Unmute.
Yeah, 66-year-old sleeping in afternoon when he got up, he complained of central vision loss, bilateral eye. Patient was on amiodarone from cartilage side. So
this could be NaON. Amiodarone, bilateral disc edema, 66-year-old. After sleeping, when you sleep, you get a hypoperfusion of the optic nerve head. So it need not be a night sleep. It can be a sleep at any time to reduce the pressure to the eye, the flow pressure, the blood supply to the eye. This looks like what he's saying is amiodarone-induced NaON, bilateral optic disc edema, and that is one of the possible causes.
In the question box, there is one more question, Dr. Guru. If there was abrupt unilateral ptosis and third nerve palsy, the pupillary light reflex is preserved, would you order a CT angio? In the question box, you can please read that. Q&A box.
Yeah. Vishwanathan, you want to take this?
Yes, sir. So when there is an acute onset third nerve palsy without risk factors, we would obviously do imaging. Now, the preferred imaging modality would be an MR. The resolution of an MR angio to pick up an aneurysm of more than 3 millimeters is probably 75% sensitivity. And if you see, and if you really want to rule out an aneurysm size, the size of an aneurysm to cause a third nerve palsy should be around 4 at least. So MR angio itself would be a reasonable choice along with an MR. It's better to club both than do a CT angio separately. The other thing about it is that without pupillary involvement, of course, there are many reports of aneurysms presenting with third nerve palsy without pupil involvement. So it's not very odd. And I think it is a reasonable differential to rule out in any patient without any risk factor for third nerve palsy.
I think I'll just add a little bit to this. This is a common situation. Pupillary light reflects the significance in these things. So the rule is, if the patient has a complete third nerve palsy and pupillary reflex is preserved, then it is unlikely to be compressive. If it is a partial third nerve palsy and it is preserved, you cannot be very sure. So the important thing is whether it is a complete third nerve palsy or partial third nerve palsy. In this case, if the patient has a partial third nerve palsy, then I won't give any importance to the pupillary light reflex and go ahead with angio. On the other hand, if you had a complete third nerve palsy, everything is gone except the pupil, then it is most likely a non-compressive. That is the clinical, guidance.
Yes, sir. I agree. Yes, sir.
But for microangiopathic complication of either diabetes or hypertension, does 3T MR or any high resolution images you think, because most of these MRs don't give any specific result? Is there any other investigation modality? Can we pick up anything strategic infarct to explain the third nerve palsy, either at the nucleus or the nerve level? Vishnu?
Sir, I think mainly we do MR just to make sure that there is no other problem. If it is some sort of an ischemic neuropathy of the third nerve, I don't know if we can actually do any particular investigation to prove it. Probably we just do investigations to rule out other causes. Like I remember one patient presented similarly with this kind of third nerve palsy with some mild headache, and it ended up being tuberculous meningitis, presenting as third nerve palsy. So you never know what you will find. So we do investigations basically to rule out other diseases, just so that we can probably just pass it off as yes, probably it is ischemic. I am not aware that of any investigation that can conclusively prove that it is an ischemic neuropathy. Maybe Sharma sir, can you? Do you have any opinion about that?
No, we have not found any lesion. So many MRIs we do for these patients, we never successfully picked up any lesions. But we didn't do a dedicated study.
Meenal Joshi has asked steroids in EION.
Sir, just one moment, Sharma sir. Sometimes we do see, I don't know, our neuroradiologist who also visits St. John's, Sharath has sometimes shown us diffusion restriction of the nerve and all that in ischemic neuropathy. That is very rare though. Yeah. But I think I have found it very difficult to pick up those things. Only in optic now I have been able to pick up in NAION, then third nerve and all. Sometimes he has showed, but we have not been able to really pick up in an offhand glance. So we have to assume it's microangiopathic and proceed. Sorry, Guru sir, you had asked.
You take this question from Dr. Meenal Joshi. She's asked steroids in EION.
Steroids in well, I do use steroids in NAION. Of course, arthritic one has to use, but in non-arthritic also I use pulse followed by steroid taper. There's no conclusive data supporting it, but we found good results with all our patients. I've been using it for nearly 13 years. There's no conclusive data. I think Sharma sir also can throw some light on this. But if the sugars are well controlled, I found it not to be harmful. And many people we have seen sequential fields improving.
Is it also because it will take some time to diagnose, come to the exact conclusion whether it is non-arthritic? You're not sure, waiting for the results.
I think if it is within the first 15 days of onset of symptoms, we have given pulse. Otherwise, we have given oral steroids.
Earlier, I was using the pulse high-dose methylprednisolone. Last 1 or 2 years, my practice shifted to low-dose methylprednisolone, 125 mg, which is as good as 1 gram for diabetes-related optic.
Yes, sir. Yeah, that is a problem, sir. What we do is for pulse, we admit them usually. Otherwise, what happens is that the sugars shoot up. So
what I feel is giving 1 gram per day for 5 days in these patients, it is quite risky. Sometimes we end up with infections.
We usually give for 3 days only for NAION. I don't know, it has been since my residency days, Professor Vivek Lal gives for everybody 3 days NAION, and he says that it works well.
These
No
patients
clear
come
cut.
with lumbosacral plexopathies and
Correct,
things like
correct. That is true, sir.
All these
We have to,
cases we give
we have to be very
125
careful.
mg, 125 mg, and with insulin little bit we control that.
But
It
sir,
works as
what
well
we have
as
noticed is we've given it for hundreds of patients over the last 7-8 years. We have followed them up with serial fields. And I think Abdul sir will tell us that they have actually done well. The field restriction, which is altitudinal, becomes sectoral, and then it reduces further. We have seen them do very well, actually. And we have seen historically some patients who had this NAION who have not been treated with probably only with antiplatelets. And we have seen their serial fields are not shown much improvement. Of course, we need more systematic data to support the use of steroids, like a trial or something like that.
I think the edema subsides faster. The moment you give steroids, I think what we have seen waiting for it to subside, it takes longer duration for the edema, disc edema to subside. Steroids, I think within a month it subsides generally. Once you have given, and we generally keep the patient on antiplatelets. Dr. Sujit would agree. We keep it on antiplatelets for life almost. All NAION patients, so far what we have seen, all patients on minimum 75. If we have chronic ischemic changes in the brain, small vessel disease, then we keep it on. Dr. Sujit says 150 is better. So I think that those are two. One thing is that, and we tell them keep a strict control of the blood sugar levels and BP and other things. And there are quite some patients who have improved with steroids. Most of them have maintained. However, there are some who come with recurrent, but sometimes we don't know the cause in those, because we meet the patients for only about 10-20 minutes. What is their sugar control over the next year? We don't know. We generally don't know lipids and sugars and BP.
Yeah. Any of the panelists want to make any comment?
Guru, Dr. Shivkumar here.
Yeah, sure.
Yeah, I asked this question, how to differentiate between non-AN and optic neuritis in young patient. The reason is we see a lot of drug abuse people, younger people coming up. So in the younger patient, even without vascular risk factors, always ask for drug abuse. We have seen 1 or 2 cases where with IV drug abuse, we have seen ischemic optic neuropathic-like presentation, where we had a lot of confusion between optic neuritis and AON. And later on, during the follow-up, they revealed to us that they were abusing the drug. And the clues for this is when the ophthalmologist looks at the disc, if there is a disc elevation, which is not seen in optic neuritis, that is one clue. Second, if the vision does not recover, these are the 2 clues when you should suspect that it can be an ischemic optic neuropathy in young patients.
Which drugs, Dr. Shivkumar?
IV drug abuse, sir.
Which are cocaine?
Yeah, in newer generation, yes, sir.
Yeah.
Drug abuse is, but thing is, it's very difficult to ask this question. In many deny it. It's a very dicey question, actually.
No. We also followed the patient subsequently. After a few months of follow-up, we came to know that they are not revealed to us. So that's why I'm discussing this, because this is one point where we need to look in someone where you have AION like presentation, but without any vascular risk factors.
Yeah,
Shivkumar, I think the MRI also can yield a clue. Generally, what happens is an optic neuritis will be, in addition to diffusion restriction, there will be prominent enhancement of the optic nerve. It's not a hard and fast rule. And
no, it's not 100%. We don't see in all cases of optic neuritis.
Yeah, in all cases, most of the cases you do see. We can, it has to be windowed carefully. You do see diffusion restriction in optic neuritis. And I think we've all been shown, Sharath is the one who showed us. But in AION or NAION, generally you won't see the enhancement. You'll see the diffusion restriction, but you will not see the enhancement. It's not a hard and fast rule, but it's one way of differentiating.
Sangeeta has some question. Sangeeta.
Dr. Abdul, what is your experience with surgical treatment of intractable papilledema due to IHT?
Yeah, actually only Dr. Jyoti does, Jyoti Matalia, she does optic nerve sheath fenestration, and it's intractable. Supposing it is, my thinking is like this: if you have a field which is good, I mean, there's no defects, field defects, then I don't think you should be interfering. I think a LP shunt would be more safer, or instead of a fenestration. If you have a field loss which is progressing and field constriction, and you feel that it is going to threaten vision, then I think it should, optic nerve fenestration is a choice. But it doesn't relieve. See, what happens is you will relieve the pressure around the optic nerve, but I don't think it is sufficient enough to relieve your pressure all. I don't think it will last that long as much as a TP shunt. I don't know. I think all Dr. Sujit, Dr. Guru Prasad and Dr. Sharma can see.
Is your patient obese or non-obese?
Non-obese, sir.
We are seeing non-obese patients with severe IIH, and many of them have focal stenosis of the venous sinuses.
Yeah, he has
stenting really helps rather than optic nerve sheath fenestration. The stenting has really helped. Within days to weeks, it resolves. So you may consider that option also.
Sir, in impending visual loss, when there is severe disc edema, patient is decompensating rapidly, poor vision. I don't know. In practice, I have found shunt VP or TP to be very fast and effective. We have seen that it arrests the visual loss and sort of the pathology is reversed rather than optic nerve fenestration. So we have done for about, I think, 10 patients in the last 5 years. All of whom the process has been arrested. Some of them have had some improvement. That depends on the duration of the chronic papilledema and the optic atrophy accompanying it. But I think CSF diversion procedures are very useful, sir.
But have you had an occasion where you had IH with CSF leak? When we had
many times. In fact, nowadays, if there's a CSF leak, first the patient is referred to Abdul sir, Rauf sir, and to roll out raised ICP and disc edema. That is the first thing we do.
In fact,
because if you repair it, it will leak again.
Another thing is, if you correct the CSF leak, the IH part will increase.
That's what, sir.
So restart Diamox.
Yes, sir. Exactly, sir. That is something which we have been saying quite often nowadays.
Yeah, we have. Dr. Ravi Mohan has done quite a few surgeries and he's plugged the leak. But generally, there's not been disc edema subsequently, fortunately. I think we should keep a close follow-up, I think, right?
Yes, sir.
So I think we are already 9:18. So if, I think we're already 20 minutes away from the thing. So Dr. Sharma, you want to?
Yeah, I think that's fine. Congratulations to all the speakers and panelists. Excellent discussion and excellent presentation. Thank you.
Thank you, sir.
Thank you, sir. Yeah. So I'd like to thank Dr. Sharma for chairing the session and beautifully conducting the session. I want to thank all the speakers, Dr. Rauf, Dr. Sujit, Dr. Vishwanathan for excellent talk, and especially Dr. Sujit for coordinating this webinar. I'd like to thank Microlabs for sponsoring this event, Hallmark team for excellent platform. So we will have this type of more practical things going forward. Probably we're planning a neuro-urology webinar for the next probably this was scheduled in September, but for various reasons we couldn't do that last month, and we're doing on 1st of October. So we'll have one more webinar this October, probably on neuro-urology. So we are collating the data. I mean, collating the speakers, and we'll probably soon have the program scheduled. Thank you all, and all the audience and who interacted, had a lot of questions, and for the interaction. Thank you all.
Thank you, sir.
Thank you, sir.
Thank you, Sharma, sir.
Thank you, sir.
Thank you, everybody.
Thank you, everyone.
Dr. Sharma, I'm seeing you after a very long time, actually. I have seen you in St. John's. I don't know if you remember me.
Yes, yes.
There,
Nice to see you.
St. John's, I studied my MS. You were a assistant professor that time when I was doing my MS.
Nice to see
He would be a neurologist if he is not an ophthalmologist.
Yeah, no, really. I loved neurology, but there were only 2 seats in NEMANS at that time. I never got neurology. I tried 2 years, but I never got. I always wanted to do medicine and neurology both together, but I never got a seat at that time. But this is the only chance I.
In Sujit at Narayana.
No, but I am very happy because I get to talk to you, all of you, and you all are very nice to me. And so that's very nice of you all, actually.
But interacting with sir, we sit together, Sharma sir, in one OPD only. So we learn a lot interacting with sir about Abdul sir about fields and all that. So it is quite an interesting experience, sir. We learn a lot.
Vast field by itself.
Yes, sir.
Not
Yes,
easy
sir.
at all.
Not at all, sir. Yeah. So we get some instant doubts cleared sitting with sir.
Yeah.
So bye then. Sir.
Thank you.
Thank you, sir. Good night, sir. Good night, sir.
Bye.
Okay. Thank you so much.